Good morning. My name is Kevin Hatton. We're going to finish our two-part talk on anesthesia keyword review with the topic of critical care. This is part 2 of 2. Yesterday we had part 1 of 2. Today's topics will be shock states, sepsis, resuscitation fluids, a few issues on nutrition, burns, and then drowning. So we'll start with shock states. And shock states are a little bit like a whirlwind. They sort of rapidly come on, or maybe slowly come on, but they get worse and worse and worse over time, and it's just this downward spiral, and it just gets worse and worse and worse. So circulatory shock is a syndrome of reduced tissue perfusion. It has nothing really to do with hypotension. It has really everything to do with tissue malperfusion or tissue hypoperfusion. And the essence is that there is inadequate capillary blood flow or inadequate capillary blood flow substrate to supply the adequate oxygen and glucose requirements to the individual cells to meet their basic metabolic requirements. We talked briefly yesterday about the oxygen cascade from the atmosphere to the mitochondria. This is sort of the second part to that. If you don't get enough oxygen to the mitochondria, you don't get enough ATP production. But if you don't get enough building blocks to the mitochondria or to the individual cells, regardless of how much oxygen is in the blood or how much glucose is in the blood, if you don't get enough to the cells, then you're going to have the same outcome. You're not going to make enough ATP. You can't keep your cell membrane channel pumps working, and your electrolytes become unbalanced, and you ultimately have cellular degradation. So shock represents a final common pathway for multiple types of what I think of as cardiovascular failure. The overall mortality rate remains very high for people in shock, in large part because of the underlying problem, as well as the downstream consequences of shock. So the data suggests that in some types of septic shock and or cardiogenic shock, the mortality rates may be as high as 50%. There's sort of 3 phases of shock. The first is reversible or early shock. In reversible shock, tissue malperfusion triggers a very complex set of reflexes at both the macrovascular as well as the microvascular and even the cellular and immunologic level that are really aimed at maintaining both cardiac output and arterial pressure. So you sacrifice downstream to maintain at least central core, central pump activity. Organ system dysfunction, distally or systemically, may not really be present or may only start to become present in this sort of early reversible stage. If shock is not reversed, then we continue onwards to this late shock stage where tissue malperfusion starts to compromise coronary and other coronary arteries and the heart and other organ systems perfusion, despite all of the reflexes designed at maintaining homeostasis. At this point, organ system dysfunction starts to become apparent, and it becomes increasingly obvious. It's not like an A, a B, a C. It's not 3 distinct categories. It's a continuum of which it's very clear we're in one phase. No, it's very clear we're in the other. And oh my gosh, it's very clear we're in the third phase, the terminal or irreversible types of shock. In this, you have significant vasomotor dysfunction. Your body gives up, for lack of better terms, and you have just vasomotor dysfunction occurring with loss of alveolar or arteriolar tone, and you get a paradoxical increase in your venous tone. So your central venous tone starts to increase as a not as a protective mechanism, but as a completely dysfunctional mechanism. At this point, irreversible organ system dysfunction becomes very evident, and whatever injury you have has converted from ischemia to infarct. And the next step is necrosis. And frequently, we don't necessarily catch people in shock till they're infarct, and till they're in the infarct phase. So all we can really see is the necrotic, is them sort of becoming necrotic instead of recovering. So it's unfortunate, but frequently we see folks who are already in this terminal stage, and we do a lot of activity to try and get them back to the late shock stage, but we're already sort of in an irreversible part of life or death. Shock states, there's basically 4 different kinds that are frequently described. I think of them as, are they either hyperdynamic or are they hypodynamic? The only hyperdynamic is usually distributive. Sometimes people would consider hypovolemic a hyperdynamic state because the heart tries to push out more and more stroke volume but just physically can't. So the overall contractility becomes stronger. So in distributive, your cardiac output is increased, your systemic vascular resistance is decreased. Usually your mixed venous saturation is elevated because blood doesn't get to your distal cells, and your wedge pressure may be decreased, is usually decreased. In hypovolemic, you have generally a decrease in cardiac output, an increase in systemic vascular resistance, a decrease in mixed venous saturation, and a decrease in your wedge pressure. In cardiogenic or pure cardiogenic shock, you usually have a decrease in cardiac output, an increase in systemic vascular resistance, a decrease in mixed venous, but a rise, an increase in your wedge pressure. And in obstructive shock, you typically have a decrease in cardiac output, an increase in systemic vascular resistance, a decrease in mixed venous saturation, and an increase in the wedge pressure. Hyperdynamic shock states are characterized typically by an increased cardiac output, specifically an increased contractility. The heart tries very hard to continue to maintain an appropriate amount of distal or systemic and regional perfusion by rapidly increasing cardiac output. In addition, hyperdynamic shock is typically characterized by a decreased SVR, and this is sort of the overlying principle. The decrease in the afterload, the decrease in the systemic vascular resistance significantly helps the shock, is the underlying reason for the shock, and also increases cardiac output. Filling pressures typically can either be increased or normal depending on volume status, particularly in the early portion of distributive shock. The longer that goes on and the underlying etiology, the overall filling pressures or the fluid balance of the patient may be dramatically decreased. Shock caused by maldistribution of blood the blood flow goes to the wrong parts of the body, right? It stays central rather than going to the peripheral tissues. So the overall flow may be increased, but the individual tissues, the distal tissue perfusion is dramatically decreased. And this is all, we can all picture a patient or 2 or 10 or 100 in our minds that all have this very central blood flow that's quite good, but very poor distal blood flow. A very classic hyperdynamic or very classic distributive shock. Hypodynamics typically characterized by low cardiac output and increased SVR. These two things, cardiac output and systemic vascular resistance, typically go hand in hand no matter what type of shock, and are typically inverse of each other. So one is up, one is down, or vice versa. Filling pressures may be either increased or decreased depending on the subset of shock that's involved, and organ dysfunction is typically related not necessarily to the amount of distal perfusion, but to the amount of global blood flow. So in cardiogenic shock, it's not that you have poor regional flow, it's that you have poor systemic flow, and therefore also have low peripheral flow as the reason for the shock state. Sepsis is a specific form of distributive shock. It is a condition of pro-inflammatory imbalance. It's a disordered response to a severe infection, and there's a genetic component that's likely to predict outcome. We don't totally understand what the genetics of sepsis are, but we know that if we give 2 people the same infection, one of them may develop severe sepsis, septic shock, and one of them might develop only very mild sepsis. So there's clearly a genetic component that is still being investigated, which is still sort of a problem. Early recognition is the key to survival, and for me, I tell residents and fellows, you should think of sepsis, particularly septic shock, as a code event. There is a time component for reversing the shock and/or reversing the inflammatory state, and time is survival. Sepsis definitions are today a little funny, And I've sort of struggled with how to answer this in an anesthesia keyword review, because we're about 12 months, 13 months now from the publication of a slightly revised or a significantly revised version of sepsis definitions. I think in this setting then it's difficult to really talk about keywords other than to say the ideas of SIRS and sepsis and septic shock are still the same. There's still underlying inflammation. There's still underlying inflammation with an infectious component, and then there's still shock. But the individual diagnoses and individual definitions that make up each of these categories have slightly changed. And so I suspect that we're in a time of flux for which, as we move forward over the next year to 2 years, we'll have better answers about how to more specifically just define these on any exams, any questions, any review that you might need. So for now, realize that these 4 things are a bit of an older definition, but are probably still, or may still be relevant in certain situations. So in septic shock, treatment guidelines are published by multi-specialty consensus guidelines. I'll admit there are new guidelines as of about 2-3 weeks ago, not significantly different from what we're going to talk about today. Again, this is an area of ongoing significant research. The underlying treatment guidelines and resuscitation guidelines haven't changed dramatically, so the big picture idea is not different. The individual sort of statements about how to change them are a little different. So use that with a grain of salt. So in resuscitation guidelines for septic shock, sort of broken down into a couple of pieces. There's initial resuscitation and how to do initial resuscitation. There's diagnosis and how to do diagnosis, empiric early aggressive antibiotic therapy, source control, draining abscesses, removing any infected hardware or other sources of infection, fluid therapy, vasopressor therapy, inotropic therapy, and steroid therapy. In terms of septic shock, fluid resuscitation, there's no real good convincing data one way or another that crystalloids or colloids are better or harmful. There are some specific small populations where colloids have been shown to be harmful. But taken in a broader view, the reality is one is not better than the other. Fluid challenge techniques seem to be the best methods for determining who is going to be fluid responsive, and these could be passive leg raise or so-called dynamic monitoring, which can be sort of found in other keyword review. And the idea that targeting a single static CVP of 12, 15, 8, whatever a number, is now highly controversial, and based on literature from the last 2 to 3 years is actually not even necessarily recommended anymore. So please realize that this is sort of an area that's consistently in flux. So patients with significant evidence of hyperperfusion may require extreme amounts of fluid, 10, 12, 14 liters of crystalloid over the first 24 hours, and that we're learning that probably just as importantly, they need fluid very rapidly to maintain or restore homeostasis, but they also very rapidly need that removed on day 2 or 3 once that initial inflammatory response is over. And there may be just as much harm from not removing that fluid from the patient aggressively as there is not giving it to them aggressively. These are, again, areas of ongoing significant research. So the old idea of evidence or of early goal-directed therapy, we dogmatically taught for a period of time, do this, then do this, and don't move to the next step until you've completed this step. The reality is that multiple trials, most specifically the process trial, which demonstrated in a very unique way or in a very positive way that it makes no difference whether you use your brain and your best clinical judgment or whether you follow the published guidelines. In reality, that makes sense, because to think that any one patient or any group of patients is going to need the same static measure of fluid responsiveness or resuscitation makes very little sense in sort of the big picture. So I would urge you not to dogmatically choose early goal-directed therapy, but instead to use the principles of early goal-directed therapy, early fluid resuscitation to restore homeostasis, early vasopressor therapy to restore homeostasis. Restore, if necessary, global oxygen delivery. The basic tenets of early goal-directed therapy are true. It's the actual mechanisms that you use to go from point A to point Z are probably not the same for every patient and probably don't make sense that way. In terms of antimicrobial therapy, remember diagnosis and antibiotics. This is key to everything, and the goal is to use the nuclear option, right? To use a very broad, extremely broad, but sort of targeted therapy. So if your patient has a risk for fungal infection, please use antifungal therapy. If there's very low risk, there's probably very little benefit to adding fungal therapy. Please obtain diagnostic samples if possible prior to antibiotics, particularly blood specimens, so that you can make sure that you can de-escalate or provide less broad or more specific antibiotics as appropriate. It does take a little time for for lung concentrations and urine concentrations to rise. So if you have to choose an order for which to get to get samples from a patient, start with blood, then get urine, then get lung. It takes time, and so if you have the opportunity, as soon as you get blood samples, then you can start giving antibiotics. You don't have to wait to get a lung sample and a urine sample. Antibiotics ideally must be given within 1 hour of symptoms, not of diagnosis, of symptoms for patients with septic shock. They should be broad spectrum, should cover all potential pathogens, and they should penetrate all potential sources. So if you have a suspicion for pneumonia, please don't use an antibiotic which has very poor penetration into the lung, right? It may have the best gram-negative rod coverage or gram-positive cocci coverage, but if it doesn't get into that area for which the infection is located, then it does you obviously no good. Blood pressure management, the hallmark here is, again, early aggressive fluid resuscitation, and if that doesn't work, please add in vasopressors. The goal mean arterial pressure is more than 65. Studies have shown it doesn't help for the vast majority of patients to aim to a higher target. The drug of choice now is norepinephrine. Here internally we use a lot of vasopressin. We use vasopressin early, but please recognize in studies of septic shock, vasopressin has not been shown to improve outcomes. The only thing it's been able to do is to show that you need less norepinephrine if you sort of co-administer it with the norepinephrine. That may be good, that may be bad, but don't use vasopressin as a first-line agent in patients with septic shock. Vasopressin, norepinephrine, as we've talked about, epinephrine is your rescue drug. So if you start norepinephrine, it doesn't work, you want to add vasopressin as a co-agent with norepinephrine, makes good sense, and if you still remain hypotensive, your next drug of choice is epinephrine. So, fluid resuscitation, norepinephrine, norepi plus epi. In terms of inotropic therapy, remember this is all highly controversial. There is no data, in fact there's some negative data, suggesting that if you shoot for supraphysiologic targets, so if you use an inotropic therapy to really drive cardiac output up, so that you maximize oxygen delivery, that actually has negative consequences to the patient, especially in terms of tachydysrhythmias. This was studied in the late 90s. So dobutamine is the drug of choice if you do need some inotropic therapy, particularly if you have myocardial dysfunction and you have a low cardiac output state. There's no significant evidence to suggest, as I've said, to suggest a benefit from supraphysiologic inotropic support. Steroids have gone back and forth over the last 10, 15, 20 years. The answer now is if you have a patient who appears to be resistant to catecholamine therapy, give steroid therapy, and if they get better, continue steroids. Please recognize that steroids may worsen systemic hyperglycemia. Your glucose may become even more out of control. So hyperglycemia and glucose intolerant or insulin resistance is common in infection, particularly common in sepsis. So adding steroids to this milieu may make things significantly worse. Activated protein C is so far past gone that it probably should be removed from this slide deck. The reality is early studies showed some benefit in patients with very, very severe septic shock. That's not really been borne out in repeated studies, so we're not going to talk about it more. So in terms of resuscitation fluids, the age-old debate, crystalloids, colloids, there's really no significant benefit or data to show benefits of colloids over crystalloids in most patients. The purported benefits of albumin and other colloids don't really pan out when you look at population studies. Even when you look at small population studies, so individual targets, even in the areas that we frequently do use albumin, there is no data to suggest it does all the things that we think that it actually does. So colloids themselves can either be classified as protein colloids, so those colloids that have protein in them, so such as albumin, or non-protein colloids, such as hydroxyethyl starches and gelatins. Today in the United States, or at least here at the University of Kentucky, we very rarely use non-protein colloids. I don't know the last time I even saw that being available to us, for lots of different reasons. There are there's a couple of places where albumin actually is indicated, and it's indicated in a different way than we used it. The first is for albumin replacement in patients who have cirrhosis, but only if they also have spontaneous bacterial peritonitis. So if you're treating someone with spontaneous bacterial peritonitis, replacing their albumin may actually improve outcomes, as well as in certain nephropathies and also in hepatorenal syndrome, using albumin replacement therapy. So that's different than using a colloid resuscitation fluid. So recognize that if someone says albumin is bad, they're probably not being entirely truthful, or they're saying only in terms of resuscitation. But of all the different crystalloid components, there's D5W, half normal saline, LR, and plasmolite. And there are a few others as well. These are the most common, and their overall electrolyte compositions. Starches, again, very infrequently used in this day and age. There was data at one time that they were beneficial. Unfortunately, it turned out that that data was manufactured. And so starches today, in the way that we understand them, are not really on the market. Their actions and side effects, though, were defined by several chemical properties, including their concentration, their solvent, the molecular weight, their molar substitution, and their so-called C2 to C6 ratios, for what it's worth. The three starches that were really used here in the United States, Hespan, Hextand, and Voluven, have different chemical structures. And the real reasons that we don't use them very often is that there was very little benefit and there's significant complications, of which the two most important are coagulopathy, particularly related to platelet dysfunction, and acute kidney injury. So folks would get starches for resuscitation during the operation, and several days later they would develop, or during the operation they may develop coagulopathy, and or several days later they may develop acute kidney injury, which in some cases even progress to the need for renal replacement therapy. So it's quite significant, and it didn't make a lot of sense, and large studies showed that it didn't improve outcomes. So in terms of nutrition, parenteral versus enteral, current sort of guidelines are whenever possible use enteral nutrition over TPN. This is something in our hospitals we do sort of naturally. So this feels for us at the University of Kentucky like a normal process, right? We choose enteral over parenteral. And the idea in the multiple studies have shown there's improved mortality, reduced length of ICU and hospital stay, and reduced ventilator days. Some portion of that is because enteral nutrition actually improves outcomes. Some portion of it is that using that prevents the complications of TPN. So some portion of it is actually a benefit. Some portion of that is also a reduction in the risk. So the TPN is usually this big yellow bag. It contains a hypertonic carbohydrate base. Instead of being D5 or D10, it's usually D50, D60, a very hypertonic carbohydrate. It contains proteins broken down into their sort of essential amino acids, electrolytes, multivitamins, and then some trace elements for which we need a continuous intake of. In addition to that, there's frequently lipids that hang alongside or are given over a shorter period of time instead of continuously. The lipids can be given over a several hour span. It's usually 10% intralipid. The same thing we use for lidocaine local anesthetic toxicity. So if you're ever in that situation, where you have local anesthetic toxicity, realize that there's nothing fancy about that, and you can just ask for someone grab the TPN fats. It contains essential fatty acids and also quite a lot of additional calories. Overall, especially in patients in the ICU, your total caloric needs are typically at least or at a minimum 25 kilocalories per kilogram per day. As we talked about yesterday, there are things that drive metabolism up and things that drive metabolism down. So a patient who's under general anesthesia, who is hypothermic and is also having neuromuscular blockade, their total daily caloric need will be less than 25. On the other hand, if they're febrile, highly inflamed, a recent burn, their caloric need is going to be significantly greater than 25. So 25 is merely an estimate to start off. The total protein need is somewhere around 1.5 to 2 grams per kilogram per day. There are conditions where the protein need significantly increases, specifically burns, major trauma, highly inflamed sources, and acute kidney injury. So while TPN is not good in general, there are a few places where TPN actually is indicated. Specifically, short gut syndrome, folks who have a high output intracutaneous fistula, significant and prolonged bowel obstruction, and then again a prolonged ileus. The major complications of TPN are infectious, in large part because you use a central catheter. So catheter-related bloodstream infections are one of the most important and most severe complications. There are also issues related to liver failure, acute cholecystitis and cholelithiasis. Refeeding syndrome may occur, and hyperglycemia may occur as well. A few extra comments or thoughts as we sort of finish out the lecture. Burns cause catastrophic and widespread inflammation. Burns are one of the worst things we can do to a human body, not just because of the burn and the scarring and the downstream consequences, but in the short term because of the enormous, massive inflammatory response that you do have. In large part because of the enormous surface area for which the injury occurs along. Burns require significant early fluid resuscitation, the so-called Parkland formula, which is nothing more than an estimate that has been, to some degree, only poorly validated. So it's just a starting point. It's not a fixed number. It's not the actual, not any patient may need more, may need less, but it is a starting point. And specific areas of concern include airway burns. So one of the things that as anesthesiologists we get involved in early is early airway protection in patients who have a suspicion for burn because of the risk of airway edema. So if patients who have soot around the nose, soot in the mouth, the potential for airway burn, we may be asked to provide early intubation well before a patient has what looks to be an obvious injury. But the concern will be that this is going to progress very rapidly to significant edema for which rescuing the airway may be impossible. So recognize that soot in the nose, soot in the mouth, soot in the spit, so if you all sort of imply an inhalational injury for which you may be asked to provide intubation. Neuromuscular blockade use in burn patients. Remember that burns cause significant changes in receptor activity as well as peripheral nerve stimulation. So with the use of depolarizing neuromuscular blockade, severe hyperkalemia may occur, usually after the first 24-48 hours. In non-depolarizing neuromuscular blockade, you may have significant resistance to the effects of non-depolarizing neuromuscular blockade. Child-Pugh scoring, very sort of somewhat infrequently used in this day and age when we talk about the severity of liver of cirrhosis, but typically A, B, and C is how things are described. Child C is much worse than child B, is much worse than child A. Today we typically talk about the MELD score, but the Child-Pugh scoring uses bilirubin, albumin, ascites, INR, and encephalopathy. Again, MELD is somewhat easier to use, but is also more sensitive and is typically used around bilirubin, INR, and creatinine. The last slide is about drowning and drowning resuscitation. Drowning is frequently lethal for a variety of reasons. most obviously from a respiratory failure. If you aspirate a large amount of water, you can't breathe a large amount of air. So aspiration of water and asphyxia with concomitant hypoxemia is the most common cause of death after drowning. But even if you're able to reverse the drowning component or the aspiration of water, it does induce an enormous ARDS response. And inflammation occurs because of the injury related to either fresh water or salt water down your lungs, which can then secondarily cause downstream problems. Most water, even if it's not terribly cold, if we think of Arctic water, right, clearly cold, but even just pool water and lake water is frequently colder than your body. So hypothermia is actually quite common, particularly for prolonged periods. You may develop cardiogenic shock because submersion causes increases in CVP and wedge pressure. You have chest, you have weight on your chest, particularly if you go very deep. So divers have this as a particular problem. And of course, you may have secondary injuries. So there's a reason they may have drowned. Maybe they fell and they've got spinal cord injury. Maybe they've got internal lacerations if they've fallen off a cliff. So there's always secondary injuries that you have to assess to ensure that they don't have. Questions for me? Thank you very much. Have a good day and good luck.